Great, well, let's get started. Thank you all for joining us today at the Connect to Science seminar series. A couple of quick reminders before we turn it over to Javed. It's just that I encourage everybody in the audience to follow the link on Javed's title slide here in order to get some updates on the Connect to Science series, including upcoming speakers. Also, during the presentation, please post questions into the Q&A section at the bottom of the screen instead of the chat box. That way we can monitor it and communicate those questions to Javed. So I'm Chris Soroshek. It's my great honor to introduce our speaker today, Javed Moslehi, and to welcome him back to Dana Farber, where he completed some of his training. Javed asked me to be brief, so I'm just going to hit a couple of highlights from his background. Javed originally got his undergraduate degree from Johns Hopkins and his medical degree from University of Connecticut School of Medicine. He returned to Johns Hopkins for his internship and residency in internal medicine before moving to Brigham and Women's and Harvard Medical School for his clinical fellowship in cardiovascular medicine. He stayed on as a research fellow in the laboratory of recent Nobel laureate, Dr. Bill Kaelin, where he pursued novel work focusing on the interface between cardiology and oncology, and essentially helped to establish and guide the entire novel field of cardio-oncology, which continues to be his primary area of research. After completing his fellowship at Dana Farber, he moved to Vanderbilt University Medical Center, where he directs the cardio-oncology program and regularly publishes some of the most pivotal papers in his field. Due to his success and his leadership in this area, he's been awarded many awards, including the Stanley J. Sarnoff Alumni Achievement Award and the Lerner Research Award from Brigham and Women's Hospital. Javed, welcome back to Dana Farber. It's an absolute pleasure to welcome you back and to hear about the cardiovascular sequelae of cancer immunotherapies.
Thank you very much, Chris. As Chris mentioned, I'm a cardiologist by training, so but I consider myself lucky in that much of my scientific training occurred at Dana Farber, and I owe a lot to many mentors and friends there. And I'll highlight this through the first part of my talk primarily. And again, as just a quick step back, I'm a cardiologist by training, although I'm involved in the care of cancer patients as much as any oncologist is, because about 10 years ago, while I was at the Farber, I decided at least the clinical focus would be the care of the cardiovascular care of cancer patients. And so I will focus for the first part of my talk about what cardio-oncology is, and then on the second part of the talk, I'll focus on some of the novel data we have with respect to one issue, which is the cardiovascular sequelae of cancer immunotherapies. I do have a number of financial disclosures. The most relevant of this for this talk is a patent we have for the use of abatacept and belatacept for immunotherapy-associated toxicities, and I'll highlight that through the course of this talk. So this is the cover of Time about 20 years ago, or a little less than 20 years ago. This is when some of the pivotal studies had been done by one of Dana Farber's own, Brian Drucker, in using in this case, a small molecule inhibitor to target the main driver of chronic myelogenous leukemia, or CML. And this was historic. This was a historic moment in all of medicine for a number of reasons. Number one, this is one of the first introductions of true precision medicine. While many, many giants in the field had defined what the driver mutation that leads to CML, here you could actually target that mutation and dramatically change the course of treatment for CML patients. And that's important because after this development, CML, for all intensive purposes, for the most part, at least the chronic phase, became a chronic disease, much like type 1 diabetes became a chronic disease 100 years ago after the introduction of insulin, and HIV possibly a chronic disease 20 years ago after the introduction of antiretrovirals. So it was actually important in that sense because CML patients were now expected to have a full life and at least not, for the most part, die from the cancer itself. There are two other reasons why this discovery and this development was important. It completely changed the practice of oncology as far as we know it, because prior to Gleevec, If you were a CML patient being taken care of in Worcester, Massachusetts, or Lewiston, Maine, you had to come to Dana Farber to see Dr. Dan D'Angelo, for example, for the care of the patient. Whereas now, any oncologist could basically prescribe an oral drug, check a few labs, and basically have the patient go home. So it basically changed the practice of oncology as we know it. The other issue that's important is these effective cancer drugs, people had to be on lifetime in this case, and that meant a lot of profits. And at least I believe as a result of, partly as a result of this, and even though Gleevec works quite well, a number of other drugs were developed that came to this space, literally by every other company, for the treatment initially of resistant CML, which I'll get to in a minute, but for the most part, frontline treatment of CML. And what was interesting, and this is where a cardiologist may come in, some of the second generation drugs specifically had noted cardiovascular issues. And this was important for the first time because now the patient was expected to live. So you did care what happened and if the patient had a heart attack 5 years after diagnosis of CML for the first time. And so these cardiovascular complications with these specific, in this specific space became a new dimension for the care of the patients. And this story takes a quick turn, and I'll get to that later in the course of this talk. So the idea that cancer drugs may lead to cardiovascular issues is nothing new. 40 years ago, more than 40 years ago, at the Dana Farber, Steve Salen, who was taking care of kids who had cancer, who was giving them anthracyclines, realized in collaboration with a cardiologist there, Steve Lipschultz, that these kids who are being treated successfully with cancer and receive anthracyclines grow up to be 20 and 30 and have heart failure. And almost everybody can tell you 20-year-olds are not supposed to have heart failure. It's interesting because even to this day, we're now beginning to realize some of the underlying pinnings of anthracycline to zero cardiotoxicity. So for example, just a few years ago, work done by Chris Sorosiak and Tony Latai really for the first time demonstrated why it was the kids that were particularly susceptible to the development of cardiomyopathy. But if you again take a step back, you realize that drugs like anthracyclines, anti-metabolites, and if you irradiate somebody's entire chest, are effectively archaic drugs. They're poisons that we were effectively giving patients. And you may imagine that it's not probably surprising that you may have cardiac issues later on for the patients, especially that survive. What has been more surprising are recent developments over the last decade where targeted therapies specifically lead to cardiovascular issues. So every breast oncologist is aware of Herceptin, trastuzumab, that leads to cardiomyopathy, where breast cancer docs have to do these painful echoes through the course of the treatment. And right about 10 years ago, as I decided to, or a little more than 10 years ago, when I decided to come to the Farber to work at Mayor 4, Bill Kalin's lab, I also realized that other drugs were being introduced that were leading to cardiovascular issues. So specifically in Bill's lab, and this is work of many people at the Farber, including most recently Tony Schwery, the introduction of VEGF inhibitors had been for the first time, a treatment option for the patients with RCC. And in these patients, we see hypertension, heart failure, and thrombosis. But to be fair, some of this was not really defined. We didn't know what the mechanisms were or how common this was. And so this was interesting, and this was in many ways my introduction to the field, because when I started in Bill's lab, or a little after Bill's lab, somebody came in and said, well, you should really have a clinic and see these patients. So just to take a step back again, these drugs target VEGF, and they're either monoclonal antibodies that target circulating VEGF or the receptor itself. But the majority of the drugs are actually small molecule inhibitors that target all of the VEGF receptors and also other kinase receptors. And at least at the time of the writing of this paper a couple of years ago, 9 drugs had been approved in this class. But going back again to my clinic now at the Farber, we began to see patients who had cardiovascular issues as a result of VEGF inhibitors. So this was a 44-year-old female, this first patient, who was being taken care of by Suzanne George and George Dimitri with GIST, who had received sunitinib, who actually was from Philippines, flew all the way to Dana Farber to see Suzanne. And after being on sunitinib, developed this heart failure. And for the non-cardiologists in the room, this is a function of the heart, and the heart's function is just not coming in too well. So we began to see cases of cardiomyopathy as they occur with these VEGF inhibitors. This next patient was a patient of Jeff Meyerhart, who had received bevacizumab, was actually an ultra marathon runner, meaning he ran one marathon and then ran another one. Had never had cardiovascular issues, but after the second dose of bevacizumab, developed what is a heart attack. And I think cardiology should be easy because this is all about plumbing. And you can see a nice blockage right here. And so we began seeing patients who had cardiovascular issues, which in this case included vascular disease. And really the 900-pound gorilla in the room was hypertension, although fairly manageable in most of the cases. It was something that we began to see as soon as the drugs were being introduced to patients. So again, at this point, under the mentorship of Tony Schwery, who was treating a lot of these patients, one basic question that we asked was whether this cardiomyopathy in this case, what seemed like the most serious cardiovascular issue, was a one-off thing we would see in the clinic, or is it a general thing? And very quickly, it became aware that about 10% of the patients treated with VEGF inhibitors develop an LV systolic LV dysfunction. So the heart squeeze kind of goes down, if you will, with a subset of those developing clinical heart failure. Over the course of several years in Bill's lab, we at least were developing several mouse models that we thought may inform at least one plausible pathway by which the cardiomyopathy occurs. And in this case, at least the model would say that inhibition of VEGF and PDGF would lead to microvascular dysfunction in the heart, would lead to chronic myocyte hypoxia, would lead to stabilization of the master transcription factor HIF-alpha, which pair up with HIF-beta, driving many issues that in part were protective, but also over time could lead to chronic cardiomyopathy. And at least one other group used another genetic model showing that this was in fact reversible. And the way we tested this was to forget about this first part of the pathway and just target on this part, either inhibiting or deleting the inhibitors of this pathway, the eglins or VHL, or stably expressing HIF-alpha, which couldn't be hydroxylated, therefore it couldn't be ubiquitinated in hearts. And this was sufficient to cause cardiomyopathy in mice, very similar to what we were seeing in our patients. Again, one other bit again was at least preliminary, this looked to be reversible. And so one basic question that we asked from the lab was whether this was something that was going to be true in patients. So among the patients that we saw in clinic with sunitinib or sorafenib or whatever kinase inhibitor that's a potent VEGF inhibitor, we saw reversibility of the cardiomyopathy shortly after stopping it, perhaps consistent with the mouse model that we could see. What was also interesting, and again, this is really a testament to Bill and some of the discoveries, was much of this pathway, again, was discovered as a result of curiosity as to why patients were susceptible to cancer who had von Hippel-Lindau disease, why kidney cancers were so bloody, for example. And this has led to potentially defining this pathway with respect to cancer treatment, most notably by the introduction of HIF-2 alpha inhibitor for the treatment of kidney cancer patients. But at least for me as a cardiologist, I think the other side of this is how this pathway, which is a central pathway by which cells respond to hypoxia, can drive things like erythropoiesis, and more recently that's led to development of eglin inhibitors most notably this fibrogen drug that's may be very effective for treating patients with anemia. But also as a cardiologist, at least thinking about how HIF acutely could be a protective, and it could at least be a plausible mechanism by which we can have cardioprotection. And so I'm bringing this up mostly, since this was all in the past, data that I think where this understanding and looking at patients with specific toxicities can inform other biological pathways that for me as a cardiologist can be important. One thing that is interesting for these patients, as I mentioned, the 300 or 900-pound gorilla is the hypertension. And one other thing that's interesting is the patients who get the VEGF inhibitors who quickly develop hypertension, many of them also have proteinuria. One of my mentors at the Farber, Ben Humphreys, pointed out to me that there is one other condition where you have hypertension and proteinuria together, and that's 3 to 5% of pregnancies that lead to hypertension and proteinuria. And what was amazing is right across the street at the BI, a young scientist, nephrologist by the name of Anand Karumanchi, had actually delved into mechanism of why pregnancy-associated cardiovascular issues, and specifically pre-eclampsia occurs. And he had identified one soluble factor by the placenta, soluble FLT1, that drives this process. And what's amazing is it actually took me embarrassingly 2 weeks to realize that soluble FLT1 is just another name for soluble VEGF receptor 1. And in many ways, much of what we see with pregnancy-associated cardiovascular issues mimic what we are seeing in our patients. And we have parlayed this in the form of a number of grants where we're defining further the mechanisms of why hypertension proteinuria occurs in this subset of patients getting VEGF inhibitors in the hopes of translating that into other more broad cardiovascular issues, and certainly the pregnant women who have cardiovascular issues during pregnancy. I told you I would go back to the CML story because, as I mentioned, this story will take a little bit of a turn that, again, introduces the cardiovascular issues for the patients. And what I didn't tell you, one of the other kind of major discoveries or advancements in medicine that occurred with CML was work done by Charles Sawyer specifically that showed that if you treat patients with imatinib, they develop resistance to imatinib over time. And specifically, you can have a missense mutation in one of the amino acids, a threonine that becomes an isoleucine in the form of a T359 mutation, that in this case renders the CML resistant to all the existing kinase inhibitors I mentioned earlier in the talk. And so a small pharmaceutical company in Cambridge by the name of Ariad developed the super Gleevec, if you feel. This was the drug that worked against all the mutant and resistant CML cases. And the drug worked wonders. Dan DeAngelo was involved in this pivotal study. In fact, the FDA was so excited about ponatinib that they actually approved it after the phase 1 trial about a year before this paper was published. So this was back in 2012, was the drug was for all intensive purposes approved for patients who had developed mutations and were resistant to the unknown kinase inhibitors. The pivotal phase 2 trial of ponatinib was published on the print version on November 7th, 2013. And this was a historic paper for the New England Journal of Medicine because the editors rushed to get the paper out. In this case, not because the patients and the doctors knew about the drug. As I just mentioned, the drug was approved a year earlier, but rather because the FDA had decided to actually pull the drug from the market. And so Dennis Grady of the New York Times gets slightly melodramatic when she says this, but effectively the drug was causing a number of cardiovascular issues, upwards of 20% of the patients who, as she describes it, had severe and sometimes fatal heart attacks, strokes, blindness, loss of blood flow to the extremities, serious enough to require amputations. And so this was interesting because actually the editorial that came out for this paper touted the drug as the next best thing, even though the drug was pulled from the market. And so in the midst of this debacle, we were asked to comment on what this means for cardiovascular issues. I think one thing to point out is this is a good problem to have, number one. But I think one of the issues that becomes, and one of the obstacles that really limits our ability to help these patients with vascular toxicities is there are fundamental shortcomings actually in phenotyping these toxicities in patients. No one in this case had a clue about what the nature of vascular toxicity is. Was this thrombosis? Was this atherosclerosis? Or was this vasospasm? And while these distinctions may appear trivial to an oncologist, cardiovascular physicians treat each of these conditions or at least prevent them very differently and with different drugs. I think the other issue that we thought was important is we must get better at identifying patients at risk. And just as precision medicine had revolutionized cancer treatment, a similar personalized approach we felt must be incorporated into toxicity assessment. If you walked into any cancer doctor in the US in 2013 with a T315 or with CML, after getting genetic testing only and after realizing you had T315I mutation, for example, you would be started on ponatinib. So this was precision medicine as much as you wanted. But once you were started on the ponatinib, no doctor, no oncologist could tell you which 20%, let's say, of the patients would have a heart attack, would have a stroke, or would have their leg chopped off while they were on the drug. And we felt this was at least a pressing need in terms of defining who is at risk when they're developing patients. I think for me as a cardiologist, another important issue is these drugs being targeted and defining specific cardiovascular issues could provide us some insight into the underlying biology, something we lack in cardiovascular medicine. We've been treating heart failure for the last 50 years, and really we don't have much mechanism-derived drugs that really come to the market that really help with heart failure patients. Whereas if you have developed heart failure on a new cancer drug where you know the potential pathway, that may give you a clue about heart failure development that may be generalizable to other forms of heart failure. And at least right at the time I was leaving the Brigham and Dana Farber, I really decided to bet my career on this. And this is a paper we wrote with a number of colleagues, including George Dimitri at the Farber, where again, underpinning this patients with cardiovascular issues, because I felt as a new investigator would allow me to define new clinical syndromes, define new problems to tackle. And there was this hope that these new clinical entities and understanding the biology could really offer some insights into the human cardiovascular biology. And so the truth is, I wasn't so much interested on as much on top of this iceberg, but rather all of the new developments that were coming through the pipeline that you oncologists were giving patients. And I'm proud to say we've been able to drive some of this forward in terms of offering new mechanisms for underlying cardiovascular issues. And unfortunately, I won't have time to talk about most of them. I'll focus on one topic specifically. But I'm also proud to say some of the collaborations still exist to this day with people at the Farber. So for example, a percent of patients who get ibrutinib, a BTK inhibitor, develop arrhythmias and atrial fibrillation. And in collaboration with colleagues like Jennifer Brown, we're about to embark on a large study to try to understand why patients get atrial fibrillation. And for the 6 million Americans or 7 million Americans who have atrial fibrillation, we really don't have much understanding of the underlying pathway. And in my work that we've developed in the mice, we've been able to at least think of one possible off-target effect of ibrutinib that drives the atrial fibrillation. And we hope that introduces new kind of pathways to explore for garden variety atrial fibrillation. In collaboration with people like Paul Richardson, we've been looking at myeloma patients and why so-called immunomodulators, which was shown by Ben Ebert and Bill Kalin to be E3 ubiquitin ligase activators, if you will, lead to thrombosis. And so that's been one area we've been investigating. And just because I learned a few years ago that if you want to have any oncologist come to your talks, you have to say something about immunotherapies and checkpoint inhibitors. I'm going to focus the rest of this talk on some TAC forms we're building on, where patients may have cardiovascular issues as a result of immunotherapies and specifically immune checkpoint inhibitors. I think it would be important for me to acknowledge a great partnership we have at the Vanderbilt. This is my good friend, Doug Johnson, who leads the melanoma program, and Justin Balco, a brilliant cancer biologist. And so much of what I'm going to talk about over the next 20 minutes centers on this very nice collaborative work. And I think we were all under 40 at the time this picture was taken. So we're young and naive, but that's what this came about. So I don't think I have to tell anybody in this group about what immune checkpoint inhibitors are and what immune checkpoints are. Very simply, in the setting of a T cell getting primed in the lymph node and later attacking other cells in the periphery, you have activators, the initial TCR recognizing the MHC and the antigen, helped by a second signal, which is a co-stimulation signal. But this is all attenuated, if you will, by immune checkpoints that attenuate the immune response. So for example, at least the dogma is now in the periphery, I'm sorry, in the lymph node, CTLA4 inhibits the T cell becomes super active, if you will. And in the periphery, it's PD-1 and PD-L1 interaction with the host cell that attenuates the immune system. And again, you can imagine a scenario where a tumor cell or an HIV-infected cell, it turns out, can hijack this system, rendering itself invisible to the tumor immunology, if you will, and the T cells and other immune cells. And what the drugs do are actually pretty simple. They target these checkpoints, and in reasons that I would argue we completely understand. A subset of patients getting previously deadly cancers like melanoma or kidney cancer or lung cancer have significant response and, dare I say, survive in the setting of cancer, these deadly cancers. And I make this slide every few months, and literally a new drug comes to the market that's been approved. That's either, at least for now, CTLA4, PD-1, or PD-L1 inhibitors. One thing that's been different now is we're combining these therapies either together, so for example, combining a CTLA4 and a PD-1 inhibitor in hopes of better response, and that's what we're actually seeing, at least in the melanoma space. But this has led to also what are new toxicities we see in these patients, which are so-called immune-related adverse events. And I think, truth be told, I think most patients would trade away their melanoma and they would kind of not care too much if they have a little bit of diarrhea or skin rash if the cancer was going to be cured. But about 5 years ago, after I moved to Vanderbilt, I was minding my business one day, and one of my colleagues, Jeff Sossman, came knocking on the door of a patient of his, a 65-year-old female with metastatic melanoma who had developed chest pain and shortness of breath after getting ipilimumab, a CTLA4 inhibitor, and nivolumab, a PD-1 inhibitor. I think one thing for the clinicians in a room, if you ever have shortness of breath or chest pain, walk into any emergency room in the US, you get a troponin check. Doesn't matter why. And in this case, the patient got a troponin and it was extremely high, consistent with potentially the patient having a heart attack or some other heart process, as were the CKs high. Unfortunately, this patient died quickly after coming to the emergency room. And what was also striking was that what we saw on the EKGs of the patient. So in this case, the patient had complete heart block, so a conduction disorder. And the next EKG was what we call a sine wave EKG, and that's not a technical name. That's just because it looks like a sine wave, and as you can imagine, This is not amenable to patients living, and so the patient died shortly afterwards. We're fortunate to get the autopsy in this case to at least think about what biological process was driving this. And you can imagine a number of different potential issues could arise. For example, the patient could be having a massive heart attack, which would manifest in this case. But what was striking was on the autopsy, a very striking feature that we in cardiology call the Dallas criteria for myocarditis arose. In this case, you have all this white space consistent of myocyte dropout, as my colleague Bobby Pitera taught me when I was at the Brigham and great pathologist. You have lymphocytes, or at least mononuclear immune cells in the heart. And these immune cells are next to the potential dead tissue. And so by the Dallas criteria, this patient has myocarditis. And for the oncologists who don't look at the heart every day, this is what the normal heart is supposed to look like. As Andy Lichtman at the Brigham has taught me over the years, this is what the heart's supposed to look like. And so here we had essentially a patient with myocarditis here. What was striking is that much of this was driven by T cells and macrophages. As best as we could tell, even though this is only an association, this was driven, we thought, by T cell and macrophage infiltrates into the heart itself. We collaborated with Bristol Myers at the time to actually uncover that this was not just a one-off thing again that we had seen at the Farber. In fact, we had a second patient come in with the exact same presentation a week later. But so at least we thought this was perhaps an infrequent toxicity that can arise after patients getting checkpoint inhibitors. And so how do you study an infrequent disease process that you're trying to understand better? And if you recall, I told you earlier in the talk that most of the patients getting immune checkpoint inhibitors at this point was not seen by Steve Hody or Tony Schwery at the Farber. They were being seen by the oncologist that sits in Western Mass or Eastern Tennessee, which gives the patients checkpoint inhibitors. And it became pretty clear to us that those doctors especially don't really have access to a cardiologist, or let alone a cardiologist that, any cardiologist, let alone a cardiologist that knows what ipilimumab is. And so we developed through this web-based thing a way where we could communicate with different doctors across the US. They would share the details of the patient. Again, we're trying to understand a new disease process into a REDCap database. And this allows us to at least gather information on these new patients with this new clinical syndrome. And we had, we wanted to, of course, confirm that these patients had myocarditis, and for the most part, they did. And the information on the patients would go in a de-identified manner into a large database. This has actually become a world effort. Really, we have cases from around the world. Most of the cases actually come from Europe, with colleagues in Europe, where we, for the first time, had developed a network where we at least try to understand this process better. But at least we have put together a large body, about 350 cases of checkpoint inhibitor myocarditis that we're trying to understand better. And I should also mention, much of this is driven by medical residents at Vanderbilt, and here are some of them who've driven some of this forward in terms of running this database. So what have we learned? As I mentioned, we learned early on that these patients are, with checkpoint inhibitor-associated myocarditis, ICI, immune checkpoint-associated myocarditis, have T cell and macrophage infiltration into striated muscle. What I didn't tell you is, with most of the cases, we would see a notorious arrhythmia associated with this form of myocarditis, very different than your garden variety myocarditis, where the main symptom may be systolic heart failure, where the heart failure doesn't squeeze well. And work done by a number of other colleagues, we think this occurs in about 1% of the patients, especially when you combine therapies, the CTLA-4 and PD-1. In subsequent work, looking at about 101 patients, we realized that many of the patients with fulminant myocarditis have early and unpredictable course of myocarditis itself. the median time for the initial exposure to therapy in this 101 patients was 25 to 30 days, meaning most patients received 1 or 2 doses. In this early cohort, we saw a notorious mortality rate, about 50%. And we looked hard at any risk factor that we could help identify. Is it the patient who had 3 stents placed the previous year? Is it the patients who had lupus previously? And the only identifiable risk factor we've been able to kind of pinpoint to is when you combine therapies, when you combine a CTLA-4 and PD-1, that's where the risk factor goes up higher. Although this is not to say that patients on single agent don't get myocarditis. In fact, that's where we treat most of the patients, and that's where we see myocarditis the most. And also, many of the patients have concomitant myositis, which is perhaps explainable, but for a reason we don't understand, myasthenia gravis seemed to be one of the other associated features with this, or at least a myasthenia gravis-like syndrome that goes along with the myocarditis. And this, along with conduction disease or AV block, seems to be one of the main predictors of patient doing worse and dying when they get checkpoint inhibitor-associated myocarditis. And subsequently, in work done by Joe Elisalam, who's one of our cardio-oncology fellows, we showed that this wasn't just myocarditis, but for example, with lung cancer, we're beginning to see pericarditis. We began to see vasculitis with certain types of cancers, especially, and arrhythmias. And the good news was we didn't see other obvious cardiac signals. Patients weren't having increased heart attacks, for example. And so at least that served in this large database as a negative control. The problem was the patients were still dying, and we still continue to see high mortality with patients who receive, who get diagnosed with ICI-associated myocarditis when they come to the, when they present. So we were very interested at this point to think about mouse models that may recapitulate this syndrome. The good news is many of the giants of immunology had been making these mice for the previous 25 years, and they were seeing very interesting phenotypes, none of which explained myocarditis. So for example, work done by Arlene Sharp, Tack Mack, and later Jim Allison, where they knocked out CTLA-4 in mice. These mice had massive lymphoproliferation, and they had multi-organ immune infiltration, resulting in early lethality. And of course, the heart was affected, but so was every other organ in the system. Interestingly, the PD-1 knockout mice initially made by Tasuku Hanjo did not have much of an obvious phenotype, at least in the C57 Black 6 model, until they get old, where they may have some lupus-like syndrome that's seen in the mice. Interestingly, they showed in a nice paper in 2001 in Science, in the BALP-C background, these mice developed cardiomyopathy, although this was not seen by either Arlene or Andy Lichtman at the Brigham. And so at least this seems to be a kind of not reproducible at other places. Now that could be many number of factors, including environmental factors that could drive this. But even if you believe that the patients had cardiomyopathy, it didn't replicate in any way, shape, or form myocarditis per se, because this again is a different pathological process. But what was also interesting to us was work done by Vicky Kelly, Arlene Sharp, and later Tasuku Hanjo, where in the MRL background, there seemed to be a hint of myocarditis and perhaps pneumonitis and other organs affected with the mice. And just to complete this slide, I should mention that the PD-L1 knockout mice didn't have an obvious major phenotype, at least related to the cardiovascular issues. And this was nicely shown by Arlene Sharp. So in hopes of having a model that we could study, we took MRL mice and we started treating them with the drugs. And at least when you combine the drugs, the mice have histological features of myopericarditis. I should mention that this is not an obvious clinical phenotype. You have to sacrifice the mice, and you obviously see inflammatory issues that mostly arise in the heart and vessels, actually, around the vessels. That's interesting, but it's not clinically relevant, at least at the time we sacked the mice, which is 8 weeks after treatment. And so one obvious thing as you look at the clinical data in these early pharmacological treated mice is that maybe there has to be something combined with PD-1 and CTLA-4 that really drives the ship and leads to myocarditis. And I'd love to tell you that I was the one who came up with this idea. I did not. I was minding my business again about 1.5 years ago. I got a call from Jim Allison, who had made CTLA-4 knockouts and PD-1 and crossed them. And what was interesting is as long as you had you had haploinsufficiency in the CTLA-4, about half of the mice dropped dead shortly after weaning. And this was to Jim, of course, very interesting. Perhaps it was the heart, but again, we didn't really know. I should mention is much consistent with the other models. If you had, for example, CTLA-4 knockouts, these mice died because of systemic autoimmunity. And so the interesting thing, at least with respect to where I came from, would be if these mice had myocarditis, but really nothing else, because that would be uninteresting if this was in fact just another checkpoint, if you will, that was really regulating autoimmunity. And what's really striking is that these mice die for one reason only, and one reason only, as we found out, and that's myocarditis. We see immune cells or immune infiltrates in one other organ, that's exocrine pancreas, although that's not clinically meaningful. And we spent part of the last year trying to understand whether this model replicated or at least recapitulated some of the features that we saw. So for example, we can do electrocardiographic tests in mice, and these mice had AV block and sinus arrest, much like the patients that we saw. And just to kind of put this in perspective, this is some of the patients from our large database, which have AV block necessitating a pacemaker. So at least electrophysiologically, this model replicated what we saw in patients. I should also mention that, that when you look at the heart squeeze is actually fairly normal, again, consistent with patients that we have in clinic. And at least one thing that's interesting to us, this is work done by Walter Myers and Ellis Screever in my lab. This form of myocarditis, at least in mice, and the early data coming in humans, seem to occur mostly in female patients. And this is very interesting to me as a cardiologist, because your garden variety myocarditis has been notoriously known to be more prevalent in men. Whereas in this case, our mouse data and the early data published by other groups suggests that myocarditis in this setting seems to be more female. And this is, again, another kind of angle you can look at in terms of deciphering what's could be happening. I was fortunate enough at this point to collaborate closely with my good friend Justin Balco. And this is some of this work is done by Maggie Axelrod, a very terrific MD PhD student in his lab. And I don't know if Anne LaCase, who runs a fellowship there when I left, is still in the audience. This is somebody you want to go after in the next few years. It would be a great recruit for the fellowship program. And Maggie has been able to show that much like what we see in our patients, much of the immune cells that we see in these patients, in these mice, is macrophage and T cell driven. Again, consistent with what we see in patients. With Maggie's help and Justin, we have begun to kind of get through a lot more detailed dive into mechanisms of the immune cells using single cell RNA-seq as well as T cell receptor sequencing. One thought, of course, is that this would be an oligoclonal thing, which we find in preliminary, although there's not a one clone that really defines the ship in terms of what we see in the mice. And this is an ongoing effort that we just started in terms of looking at the specific immune drivers in this myocarditis model. And so a number of grants that we just submitted looks at, for example, what the immune cells are that are responsible for the checkpoint inhibitor-associated myocarditis, what could be the target antigen if there's a defined T cell subset. And at least one other area we're interested in is I've mostly talked about patients with fulminant myocarditis, well, what about patients who get a slight increase in troponin or have what we have termed smoldering myocarditis, and what are the effects on those patients over time? And these are at least some ongoing questions that we're hoping to answer using the mice and the large database of patients that we have been able to build. Now, some of you may be thinking, well, what does this have to do for patients? Does this really mean anything? And I would at least suggest that having preclinical models where you can, if you can convince yourself, can mimic what we see in patients, preclinical models, can at least inform of potential treatment options that we may translate into patients. So for example, in this case, the main risk factor, as I mentioned, is the combination of CTLA-4 and PD-1 inhibition. And this suggests, at least the early mouse models I showed you, that CTLA-4 signaling is critical for the development of myocarditis. And so one very testable hypothesis is whether reversible of CTLA-4 inhibition, CTLA-4 agonism, if you will, is a treatment strategy for these patients. And you can explore this genetically, obviously, by giving back CTLA-4. But as it turns out, you can actually reverse parts of what ipilimumab does by what has been already a drug that's been on the shelf of at least one pharmaceutical company, abatacept, which binds CD80-86, that may potentially negate the effects of ipilimumab. Some people talk about this being a CTLA-4 agonist. That's actually not true, in that the abatacept binds the target of CTLA-4, so it competes with it. And what's been interesting to see is in the pharmacological mouse model, we can attenuate the histological features that I mentioned that we see in the mice. Although I would say this is not the most convincing data, but this is, if you go back and give the mice that I mentioned, and in this case, we focused on the female mice because that's the mice that are affected, abatacept, you can reverse the death of the mice that we see. And this correlates with less immune infiltration in the hearts of the mice. And at least one identifiable thing we've identified in the heart, in that the mice get cardiomegaly, you can at least reverse that with abatacept. So at least in the mouse model, abatacept may be a treatment option for the mice. But does that have any relevance to patients? And so I'm going to just side step here for a minute. I actually personally feel this is a great opportunity for physician scientists and cardiologists interested in this field. And one of the first things I did when I got to Vanderbilt was write a fellowship, basically, the paperwork for a fellowship, which, believe me, takes a lot of work. So we have the first GME-approved fellowship in cardio-oncology in the country. And so we've been able to hopefully train physicians, cardiologists who are interested in this field clinically, hoping that they'll also kind of parlay that into careers as a physician scientist. And I'm proud to say we have a number of fellows in the last few years who've graduated from the program. And one of the cool things with this first batch of fellows, a lot of them actually come from afar. Joe Ellie came from France. Walter Myers came from the Netherlands. In this case, Joe Ellie, who graduated from the program and has remained a close colleague, went to France and established the largest cardio-oncology program there. And Joe, after getting back to France, called me with a patient who had myocarditis, where they thrown the book at. In this case, again, the patient was paralyzed, so they had the myasthenia gravis-like syndrome. But after not responding to steroids and IVIG and plasma exchange, after receiving abatacept, and specifically 4 doses, I believe, the patient walked out of the hospital, and Joe published this in a letter to the New England Journal of Medicine a few months ago. And we now have a series of other patients who get abatacept who do well. The obvious question for any oncologist here is, what are the effects on the cancer? We don't know at this point. I think that's an important question. Although preliminary, we haven't seen a massive tumor explosion when you give these patients abatacept, but that's at least something to think about. A couple of other very quick tidbits, and I'm getting to the end of my slide. Let me see how we're doing with time here. We've also taken a deep dive into defining the immune infiltrates that land in the heart in patients with myocarditis. We have some interesting results there. And I think one of the other big questions is what happens over time to patients. You have the Jimmy Carters of the world who get the PD-1 inhibitor, who survive their metastatic melanoma. What happens to them over time, at least with respect to cardiovascular issues? And we're happy to have a new R01 that will start shortly looking into that specific question, which I think is an important one. I want to just sidestep for a minute. This was a slide given to me by one of my close colleagues here, who's now at Northwestern, Jeff Sossman, who I think many people know in the audience. And this is a slide he gave me in 2016. And this slide represents all of these trials, at least in 2016, that were happening with immune checkpoint inhibitors. And I think one thing that you can see is that it's not just melanoma or lung cancer, it's every other cancer on the face of the planet, it seems like. And so over the last few years, we now use these drugs frontline in many different settings, potentially, and that will only change in the next few years. One interesting study led by my colleague Doug Johnson that he published a few years ago is looking at some of the databases that we have to see what happens to these side effects. I mean, I'm a cardiologist, I'm interested in the myocarditis, but what about some of the other toxicities? And what's interesting is about 1.2% of the patients die shortly after getting checkpoint inhibitors. And that's before you even know if they really would respond to the cancer. And while myocarditis, thankfully not being the most common one, is the most fatal one, we see fatalities across the board with other forms of immune-related toxic effects. And so also that brings up a question of delivery of care for our patients. So if I'm in the ER looking at a patient with checkpoint inhibitor associated myocarditis, and an ER doctor hands me an EKG, I can read an EKG with the best of them. But ask me about myasthenia gravis and ask me to do a neuro exam. My neuro exam hasn't gone beyond non-focal for the last decade or so. And so I think that this also necessitates, at least in the patients that I care about, of at least a group effort in terms of trying to understand these toxicities, being that they can affect literally every organ. And so that's an idea that we have parlayed into this program at Vanderbilt. Vanderbilt's a little bit smaller, so it makes it easier for multidisciplinary approaches to patient care. And under this umbrella, we're hoping not just to bring better care for the patients, but really the holy grail here is who's at risk, something we don't understand. And that's at least one kind of hope that we have in the coming years in terms of understanding this. And this really introduces practitioners from every discipline of medicine into the care of the patients. I should mention we're not the only ones that are all thinking about this. It's been great to partner up with colleagues at Johns Hopkins in this case, and across the city from you, Mass General has a great group with Ryan Sullivan, Carrie Reynolds, who have this kind of approach to patient care. And so in many cases, as example, this recent Lancet Oncology paper, to think about partnering in terms of understanding these processes better. I'm going to leave you with a couple of thoughts. One idea that I kind of mentioned early on is it's not just the care of the patients that we care about. Certainly that's important, but we think unraveling the mechanisms of these toxicities can inform other forms of inflammatory heart disease, for example. And at least for me, this has been an eye-opening experience using some of the many techniques that are thought to be second nature in the oncology or immunology space, and think about bringing those to cardiology. And this is one of the hopes that we have in partnership with our heart failure and vascular medicine teams here in terms of parlaying this into what the role of immune system is in other forms of inflammatory heart disease. I can tell you one process that we run into a lot is heart transplantation, and specifically rejection after getting a heart transplantation. And this is the one case where we get tissue readily, because anybody who has ever had a heart transplant goes through about 14 heart biopsies over the next year. And one interesting, very associative study, simple study, for example, is this early observation that patients with acute cell-mediated rejection have worsening have higher PD-L1 expression. And although, again, this is only an association, in patients where you treat the ACR and they get subsequent biopsy, the PD-L1 goes down again. Again, at least if you think about it, maybe this suggests this pathway is important in other inflammatory heart diseases. And this is an idea that we're sort of exploring. Last couple of slides. I talked a lot about toxicities, but I think it's important to note that cardio-oncology is not just about drug toxicities or how cancer affects the heart. There's growing appreciation that common risk factors drive both cancer and heart disease, the #1 and #2 risk of death in the world. And this has been shown most elegantly by Ben Ebert with respect to somatic mutations in the blood in the form of clonal hematopoiesis. And so at least a part of the clinic is describing this. I'm also happy to report that even to this day, when I see CHIP patients, I have Dr. Steensma's cell phone, and I can text him and ask him what he thinks. And again, consistent with this great collaboration with folks at the Farber. I want to just mention a few names, people who have contributed to the immunotherapy project. A number of colleagues at Vanderbilt that I mentioned, most notably Doug Johnson and Justin Balco. A number of colleagues at the Brigham, Andy Lichtman. Luis Diaz, a good friend and old colleague and mentor at Sloan Kettering. And Jim Allison and Spencer Way, who was a postdoc in Jim's lab, and some of the funding that we have. This is the group that we have clinically of cardio-oncology here. And I am proud to say we have 2 new fellows starting, hopefully going in the track of being physician scientists. And finally, a big thank you. Again, I mentioned that much of my academic career started out and scientific career started out at the Farber. In fact, I had 2 stints at the Farber, and specifically 1 floor, Mayor 4. I was fortunate enough to get mentorship from Bill Kalin. I'm also happy to report for the last 20 years, one person I could knock on the door of is Jim DiCaprio, a great colleague and mentor. And at least at the time I left, Tony had moved into the floor and has been a great friend and mentor. And I think it was Tony that mentioned to me, one of the greatest things you will take away from this floor isn't so much us old PIs, but rather your colleagues here. And these are some of my colleagues in Bill's lab when I was there. And I'm happy to report this friendship goes beyond outside of the floors of Mayor 4. And this was Marcus Schultz. I don't know what that is. It's something Chris introduced me to. And this is with Chris and another good friend, Sam McRae. Thank you again. And I will stop there and answer any questions.
Great. Thank you so much for that, Javed. It was a fantastic talk. We do have quite a few questions, so we only have until like 5 after the hour, so we'll try to keep the answers brief if you're able to do that. So one of the earliest questions asked, are there any cardioprotective drugs that can be used concurrently with targeted therapies, that, especially those that cause cardiomyopathy?
A really good question. I would say the problem is in the heart failure world, much of what we do is not precision-based. We got lucky with a number of drug ACE inhibitors and beta blockers that are general neurohormonal antagonists, and people have tried applying those. I would say it's important to note that each cardiomyopathy is probably very different mechanistically, and for each case, we have to think about cardioprotective measures. And so I think that's one important thing to think about. There have been a number of studies, small, where patients who are at high risk of developing, say, anthracycline-associated cardiomyopathy may benefit from ACE inhibitors and beta blockers. These are general garden variety heart failure drugs that we use clinically. And there's some evidence that they may help. My argument has always been it never really hurts to start patients. Again, work done by Steve Salen and Lipschultz with kids showed that dexrazoxane, which is an EDTA chelator, may be effective for anthracycline-associated cardiomyopathy. But again, I'm first to say that each forms of cardiomyopathy here is very different mechanistically. And I think it's hard to kind of extrapolate what we see in anthracyclines to other forms of cardiomyopathy that we see.
Great. Ching Zhang has a question, something I was also wondering about. Is there any evidence that immune checkpoint inhibitors act directly on cardiomyocytes instead of through the T cells?
Great question. This is actually a question that we're thinking about. So there are actually two questions. One is, I would kind of break that into two questions. One is, are the drugs themselves doing something to the cardiomyocytes themselves? One early observation that we have that's pretty interesting is PD-L1 goes up in any form of cardiac insult, including putting cells in a dish in the form of iPS-derived cardiomyocytes, exposing it to, say, hypoxia, and where you don't have other cells, PD-L1 goes up. So you can imagine a scenario where the drugs affect the myocyte directly. I think the other question Chin may be asking, so that's something we're exploring. The other question that I think is interesting is, are the T cells directly causing death? Are they binding the cardiomyocytes in a direct fashion leading to death? Or is it an off-target, maybe other cells are affected and it's the interferon that's being produced that drives the cell death? And these are two questions that we're exploring in collaboration with Justin at this point. Great question.
Great. Another question from Kelly Burke. For the CTLA-4 Het PD-1 knockout mice treated with abatacept, if the abatacept was stopped, do you get a reversal of the phenotype and onset of myocarditis? And as related to that, when you were discussing the clinical use of abatacept in these patients that develop myocarditis, is there a timing issue related to the administration of abatacept that is also important for outcomes?
Great question. So for the practicality of this, in terms of doing the abatacept experiments in mice, we treated the mice after weaning, just because you got to know what the genotypes are and so forth, and it's just easier to give the drug. So that's the time we've started treatment. We actually saw this difference on the Kaplan-Meier in terms of mice dying, and then we kind of specifically stopped many of the experiments right at the 100 days. We're now doing experiments where we let the mice go, where we stop the abatacept and see what happens, and that's those ongoing experiments. With respect to patients, it's a very good question. I think one of the challenges is both with respect to diagnosis of myocarditis, because myocarditis is not the first thing people think about if you show up with chest pain to the ER. And so even the diagnosis has sort of been challenging in terms of having people think we should think myocarditis and not garden variety heart attack right off the bat. But we have now about 20 patients successfully treated with abatacept. Early data again, but again, part of this has been if they don't respond to steroids shortly after, at least if the troponins go up, we give abatacept. We have not done a controlled trial, certainly, to show whether abatacept timing matters. You can obviously become a little more maverick and say maybe abatacept should be the first drug we give these patients if they truly have myocarditis, although that's obviously something we need to explore in the more clinical trial setting, I would say.
I think we have time for one more question. This one comes from Zintis Indy. There has been some interest in combining immunotherapies with targeted therapies, for example, checkpoint inhibitors with RAF, MEK inhibitors in melanoma. Do you think this approach presents particular risks or opportunities with regard to cardiovascular toxicities?
Yeah, so this is a great question. So I think Tony Schwery, I don't know if he's in the audience, he can tell you, when he was running a trial with a VEGF inhibitor, axitinib, and avelumab, of the first 50 patients, one died, and that's 2% of myocarditis, although truthfully, it wasn't as high incidence. I think with more combined therapies, we're going to see more effects with respect to toxicity. I'm not just talking about CTLA-4 and PD-1 inhibitors. One plausible hypothesis, at least one we're exploring, is if you cause cardiac damage with another agent. So for example, if you're a melanoma patient, if you get a RAF inhibitor, RAF inhibitors have been known, actually RAF combined with MEK inhibitors have been shown to cause cardiomyopathy, although every melanoma doctor would tell you it's not a serious thing, but the patients can develop cardiomyopathy. And so when you come in now with a second hit, the question is that leading to more cardiac issues? And that's something we're exploring with the mice, but also it's an important thing to think about as we look at the patients. I would say the other really quick answer to that is we have, as I hope to convince you, we see cardiovascular issues with other forms of drugs used in oncology. So for example, if you have a kidney cancer patient who gets a VEGF inhibitor plus a checkpoint inhibitor, and if they have cardiomyopathy, is that myocarditis or is that just the VEGF inhibitor causing myocarditis? And that obviously introduces a second kind of diagnostic dilemma for the clinician in terms of deciphering what that is.
Excellent. Thanks for explaining that, Javed. We are out of time. Unfortunately, we only have till 5 after the hour, but we have a bunch of other questions, so we'll put those into a written format and send them your way, Javed, and maybe you can answer those, and we can send that back out to the attendees of the seminar series. Thanks everyone for joining us today. Thank you especially to Javed for a wonderful talk and for telling us a little bit about the world of cardio-oncology. And we look forward to the next session of the Connect to Science series next Tuesday. So we'll see you all back then.
Thank you again.